Hello, my name is Trần Thi Phụng, and I am pleased to present our research on the diagnosis performance of cervical cancer primary screening methods, an umbrella review and updated meta-analysis. And this is joint work with my advisor, Associate Professor Kulawat Thadanipon, and my co-advisor, Professor Amarin Thakkinstian, and Associate Professor Montarat Thavorncharoensap, all from Mahidol University. So today my presentation has three parts: background, methodology, and result with discussion. So let me start with the cervical cancer remains a major global health challenge with hundreds of thousands of new cases and deaths every year, and the vast majority occur in low and middle income countries, so where access to screening is still limited. So we have a clear need for effective screening tools. The disease itself is well understood. Persistent infection with high risk HPV is the main cause of cervical cancer, and progression from infection to invasive cancer typically takes a decade or two. So that is a wide window for screening to detect lesions early. So with this slow progression in mind, three categories of screening are widely used today: visual inspection, cytology, and HPV testing. So together, they give a specific tests including both clinician collected and self-sample HPV. So now, several systematic reviews have evaluated these tests, but each cover only a limited subset, often with different reference standards. For example, RBN focused only on HPV DNA, while Smith excluded LBC, and no single review has consolidated all major modalities under harmonized criteria. And that is a gap we set out to address. So that motivated our research question: how does each primary screening method perform for detecting symptoms when colposcopy directed random biopsy is applied to all screened women? And our objective is to pull the diagnosis performance of all 8 modalities under one harmonized framework. So to answer this, we follow the PICO framework. The population, the apparently healthy women with intact services. Intake tests the 8 modalities across visual inspection, the cytology, and HPV. And the key methodological feature is our reference standard: colposcopy directed or random biopsy applied to all screened women, not just those who test positive, and with minimized verification bias. So our analysis has 2 steps. Step 1 is an umbrella review of existing systematic review under our strictly eligibility, with quality assessed by AMSTAR 2 and overlap quantified by the corrected cover area. And step 2 is an updated meta-analysis pooling individual primary study using quarters 2 for quality and the bivariate hierarchical S-ROC model. So now let me move to the result. For the umbrella review, after screening over 1,300 records, 27 systematic review met our criteria, covering 570 primary studies and over 1.15 million women. And the corrected cover area was just 2.33%, indicating only slight overlap, which support running an independent meta-analysis. So for step 2, 26 studies were retained from those reviews, plus 10 new ones from updated searches, and giving 34 unique primary study. Most were conducted in a mixed as population-based screening program, and crucially, colposcopy-directed or random biopsy were applied to all screening women in every study. Quality assessment told an important story, and status score for the systematic review were predominantly low and critically low. We justify our updated meta-analysis with stricter criteria, and the 34 primary study was mostly low risk, with the main concern being flow and timing. And here are the headline results. Two methods led on sensitivity. Clinicians collected HPV DNA at 0.88 and VILI at 0.86. And cytology at the HCl plus threshold had a highest specificity at 0.99 and the strongest rule-in profile. HPV cell sampling was the weakest performance overall. And let me zoom in on the two top performance. Clinicians collected HPV DNA delivers the strongest rule out, directly supporting WHO recommendation for HPV-based primary screening, and VILI is comparable in accuracy, but the key difference is cost. VILI runs about $1 to $5 per test, and this versus 5 to 15 for HPV DNA, and that is a meaningful gap for result limited setting. So for cytology, we see a clear threshold trade-off. Access plus is the most balanced, suitable for 3-8, and SC plus has very high specificity, the strongest rule-in profile of any test in our analysis, but at the cost of lower sensitivity. So threshold charts essentially define the clinical role. As stepping back, the method sought into clear tire, clinicians collected HPV DNA is the best overall, with VILI a strong alternative, and cytology SC plus play a role. HPV mRNA and LBC are promising but limited by few studies, and cell sampling is the weakest. So from a programmatic view, where resources allow, adopt HPV DNA in a mixed setting, VILI is a viable alternative. So of course, every study has strengths and limitation. Our strength, this is the first consolidated assessment of on each modality under harmonized criteria with a stricter reference standard. And the first HS drug pooling of HPV mRNA. Limitation include substantial heterogeneity for visual and cytology tests, limited evidence for newer tests, and no stratified reporting by age or HPV status. To conclude, clinicians collected HPV DNA delivers the strongest overall accuracy for SIN2+, supporting WHO recommendations, and VILI is a viable alternative in result-limited setting. Future research should focus on head-to-head study of HPV mRNA and cell sampling with stratification by age and HPV status. So that is my presentation today. Thank you for your attention.